This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Today what we're going to do is we're going to jump into our first interview style podcast, and we're going to interview a good friend of mine, a colleague that I've worked with for a long time, Michael Verkest. He is one of our newest additions to the FlightBridgeED team. He's serving as an education consultant on the West Coast, so we're real happy to have him. And we had just completed a review course in Portland, Oregon, our fourth one in Oregon, so we're pretty thankful for everybody inviting us into the different areas of Oregon. I feel that we have traveled around the United States, and to be back in Oregon 4 times is great. Mike Verkest is, again, somebody that I've known for a long time. We've known each other for about 18 years. We've worked together as colleagues, as partners, have been involved in each other's lives personally and professionally, and I call him a great friend. So I'm real excited to be able to introduce him and introduce our podcast today. And what we're going to do is we're going to do a podcast on TXA for traumatic brain injury. And this is a new concept. This is a new study. And I'll let Mike jump in and explain what this study is and introduce himself.
Well, first of all, thanks, Eric. Man, I really appreciate the introduction there. I'm kind of a humble guy, so it was hearing you talk about our relationship and going way back. It's it's true. We've seen some stuff, haven't we?
Yeah, we have.
So, we're going to talk about a new Resuscitation Outcomes Consortium trial that we're going to be conducting. It's actually international. It's going to be United States and Canada, but we'll be talking specifically today about our participation in the Portland, Oregon metro area. So, so it should be pretty cool.
So, Mike, can you tell me or tell our listeners where you currently work, the type of system it is, kind of dynamic it is, and just give everybody an idea, lay the groundwork.
Set the stage a little bit. Sure.
Yeah, absolutely.
Yeah, so currently I serve as the EMS training officer for AMR in Multnomah County. We're a all ALS, so dual paramedics on our ambulances. We run with lots of different fire agencies. Portland Fire and Rescue is the primary one. Gresham Fire Rescue, Portland Airport Fire Rescue, a couple other smaller community-type fire agencies out in kind of the more rural parts. We're a pretty unique system. We have completely urban. We've got frontier. So we really cover the gamut in both Multnomah County and Clackamas County as well. So call volume for my area, I think we run at about 72,000 requests for service. Transport probably around 65,000. And we do have ALS first response as well with Portland Fire, Gresham Fire. It's a pretty dynamic system. We pretty much see it all up here.
Well, great. Well, for those listeners out there, this actually where I started my paramedic career was Multnomah County, Portland, and so really good to go back and see some old faces and see a system that I kind of cut my teeth on. So, Mike, why don't you explain again the Resuscitation Outcomes Consortium, how you became involved in this, and then let's jump into the study and how this applies to traumatic brain injury.
Yeah, absolutely. So basically, what it boils down to is the Resuscitation Outcome Consortium, or ROC. You might hear me refer to it as ROC. Their mission is basically to provide infrastructure and project support for clinical trials and other outcome-oriented research in the areas of like cardiopulmonary arrest, severe traumatic injury, and really it's really EMS focused. So we're really excited. We've been involved with ROC since probably the early 2000s, probably 2003, and we've been involved in a couple of studies. We did a hypertonic saline study. We're currently doing an ALP study, which is the amiodarone lidocaine placebo in cardiac arrest, kind of a head-to-head to see which one's more efficient. So we've been really participating with ROC for a long time. ROC investigators are just so involved in all phases of the trial, and we really enjoy working with them here. And plus, it's awesome to be on the forefront of EMS research, and that's super important to us.
Well, I agree. I think, starting my career in Oregon and seeing how progressive Oregon is and moving across the country and then being involved now both domestically and internationally, I can say that Oregon is one of the most progressive states out there, and they're always trying to lead the way, and so I really respect that.
Yeah, absolutely. It's a great place to work, especially in my role as a training officer, getting to work with all the medical directors, and it's very collaborative. It's very cutting, or I would say bleeding edge for some things, and it's just fantastic.
All right. So for those listeners out there, remember we did a podcast about a year and a half ago on TXA, and TXA is something that we're seeing in the protocols now. We're seeing it in a lot of ground protocols as well as the air protocols. Yep. I've used it a few times and actually saw an improvement in my patient. And so we have historically seen TXA used for massive hemorrhage, or the clinician's judgment as far as massive hemorrhage based on the CRASH 2 and the Matters trial. So can you kind of talk about both those trials and where this new trial has come from?
Sure. Well, I mean, I'm sure everyone's heard of CRASH 2 and Matters until their ears were bleeding. So I won't belabor the point. Other than that, we learned lots of things from those trials. And just a couple of the things is if you give it more than 3 hours after the injury, it's not any good. They did find out that sooner is better. And so basically within those studies, there were subgroups of people that necessarily weren't bleeding out, but they had a isolated traumatic brain injury. So what they found was that the people kind of nested within the main trial that had TBIs that got the TXA actually did a lot better. Their hemorrhage was better. Their CT scans were better. Their 28-day survival was better. So, I mean, and really, really improved in some cases up to 10% lower mortality in those people that got TXA. So that's kind of what kind of got started with this idea, because traumatic brain injury, there's not a lot we can do in EMS for it, right? I mean, we can control. I mean, once the primary injury is over, there's not much else we can do. We avoid hypoxia, which I know you talk about a lot. That's a huge. I mean, that's pretty much the number one thing we can do in the field is avoid hypoxia. And I don't know if you want to add anything to that or not, Eric, but that's like really the number one thing, right?
Oh yeah, absolutely. All the studies show that you have a huge, and I'm not going to quote a specific percentage, but I believe it's near the 50% range as far as increased mortality and morbidity when you have any hypoxia or hypotension. I think it's interesting as far as this study goes, the CRASH 2, maybe explain when they pulled this data. Obviously, the clinicians in those two trials suspected massive hemorrhage based on mechanism and things like that, right, and then were found to only have a traumatic brain injury. They were given TXA because they were thought to have traumatic hemorrhage. Turned out, based on the CT scan and the secondary assessment, that wasn't the case. So this is kind of a secondary finding that it didn't mean to happen. Is that correct? Yeah,
that's exactly the way I understand the CRASH 2 and the Matters trial as well.
Okay. All right.
Yeah. So the other thing is, in Thailand, there was another study. It was a randomized controlled trial. It was only 240 patients, and they had isolated moderate to severe TBI, and they were randomized to get 2 grams of TXA as a bolus versus placebo, and those results were basically the same thing that they found out of the Matters and the CRASH. So this little 240 patient study in Thailand really kind of sealed the deal that, you know what, we think that this really can make a difference for people with these head injuries, because like I was getting to earlier, is that once the primary injury has occurred, we have to avoid hypoxia. We can help avoid hypotension, but as far as prevention and treatment of, we can treat seizures, I suppose, if we see those, but we don't have a lot of ability in the field, let's say on the ground, to control ICP necessarily. If we see fever, there's not much we can do about that, and avoidance of hyperglycemia, which is really kind of a later stage thing. So we don't have to deal with that. So that's where the whole question of TXA and TBI came through. Was there anything else we can do? Because like I said, from the studies, we learned that earlier is better. And so the whole point of the trial is to really find out, how much earlier does it matter? Is it within 3 hours? Is that good enough? Or is it, is sooner better?
So Mike, can you explain when are you guys going to actually employ this trial?
Yeah, actually, we were scheduled to start the trial Monday, but there was a last-minute checklist that needed to go through the IRB, kind of on the hospital side of things. So we're actually looking to probably start this Thursday, May 21st.
So, Mike, can you explain to us kind of how the study is designed and kind of what you're looking at as far as your questions that you're trying to answer?
Yeah, absolutely. So basically, this is a multi-center randomized placebo-controlled trial. Say that 3 times really fast. And it basically has 3 treatment arms. The first treatment arm is going to be 1 gram of IV TXA over 20 minutes. Basically, we're gonna mix what we think is the study medication, which may be TXA or may not be, and we're going to drip that in over 20 minutes. So we're going to basically drip that in. We're just going to eyeball that 2 drops a second or so, and then when they get to the hospital, they're going to get another 1 gram over 8 hours. The second arm of the trial is 2 grams IV TXA over 20 minutes pre-hospital, followed by a maintenance placebo infusion over 8 hours. And then finally, the third arm is placebo over 20 minutes pre-hospital, followed by another placebo over 8 hours. So there's 3 treatment arms. It's going to be 1 gram pre-hospital, 1 gram over 8 hours. It's going to be 2 grams pre-hospital, and then 2 grams over 8 hours, or it's going to be the placebo. So 3 treatment arms, and we're looking forward to it, man. I'm really ready to get this thing started.
Well, that's great. Do you have an idea as far as, have you looked at the data based on your guys' run volume on potential patients that you may have?
Sure. Yeah. So overall, the study's looking for 1,004 patients that meet inclusion criteria. So over about 15 or 20 sites in the Canada and United States, they're looking for 1,004 patients. So really, our kind of cut of the deal is we're probably looking at trying to get around 100 patients, and that's pretty much what our data is going to show. And we're looking probably 12 to 14 months to get this process completed.
You said that there's multiple sites. So are you specifically talking about just Oregon, Washington, Canada, or can you kind of elaborate on kind of a geographic location? Oh,
absolutely. So I'll just kind of name them off for you. So University of Alabama at Birmingham, University of Texas Southwest Medical Center in Dallas, University of Washington Harborview Medical Center. So Seattle King County Medic 1 will be participating. Okay. AMR both in Clackamas County and Multnomah County, and our hospital. And actually the study's kind of headquarters, if you will. That's not the right term, but basically Oregon Health Science University is kind of will be receiving all the data from all the other facilities. So they'll be getting CT scans, the blood work, and all that kind of stuff. So we've got St. Michael's Hospital in Toronto, the Mayo Clinic in Rochester, Medical College of Wisconsin, University of Texas, Houston, University of Cincinnati, a few places up in British Columbia, and as well as the St. Paul regions up there as well. So lots of places involved, lots of EMS. In fact, I was on the committee that wrote the training slides for this study. So pretty cool to get a lot of input and see a lot of different scenarios from lots of different places across the United States and Canada.
Well, that's absolutely. I mean, that's great. I know you said that for your region, for Portland, for Clackamas County, Multnomah County, specifically OHSU, for those listeners that aren't familiar with that, that's one of the level 1 trauma centers in Oregon in that metro area. And the city's divided where crews have to pick the trauma center based on the geographic location. Isn't that Gleason? If it's...
Oh, you know what? Yeah, it's changed. It's some Burnside. And pretty much what we'll do is if we have a trauma entry and we're somewhere it's not completely obvious, we'll just call up and say, this is where we're at. Where do you think they should go? And they'll send us to one of those. But the interesting thing about, and not to get too far off the subject, but the interesting thing about this trial, we have 2 level 1 trauma centers in Oregon, and they're both happen to be in the city of Portland. So we're pretty fortunate. Our patients are fortunate for that. But only patients that are going to be going to OHSU are going to be able to be enrolled in this, and there's some other reasons why they can't go to Emmanuel, and mostly it just revolves around study personnel and some lab tests that have to be done that they just don't have the ability to do. So it's only patients that are going to OHSU.
All right, great. Well, that's pretty neat. Can you talk a little bit about what the crews are going to be facing as far as inclusion criteria?
Oh, absolutely. And it's pretty interesting too, because with any kind of study, making sure that we enroll the right patients is huge, right? So there's a lot of things to remember on top of just the stuff that they got to know already. So basically, inclusion criteria for the ROC, TXA, and TBI, they have to have blunt or penetrating TBI, right? That's kind of the first one. And I'll get back to the second one here in a second, but because there's a few. All their systolic blood pressures prior to enrollment need to be greater than 90 or better, because we already know from other studies, right, that we know TXA works in people that are bleeding. So we want to make sure that these patients aren't necessarily in shock, right, at least at the time they get enrolled. So all their blood pressures need to be at least 90 or above. and they have to have an IV. And an interesting side note is we're not allowed to administer this via an IO. So, and it's just like anything, if you know anything about medical research, of course, it probably works just fine, right, through an IO, but it was not sent through the IRBs. They did not approve it to be given through the IO. So this will be IV access only. You have to be 15 years or older or weigh 50 kilograms or more if we don't know their age. And, there's some big kids out there. The people that would be in the study, obviously we have an exception from informed consent because people that would be enrolled in the study don't have the capability of declining or accepting to be in it. So we have the exception from that. And then, of course, they have to be transported to OHSU. That's kind of the last one. And then finally, and this one we spent a lot of time on, and it's going to seem rather intuitive to most people, but their pre-hospital GCS has to be 12 or less. Okay, so 12 or less, and that's prior to us opening the kit or them getting RSI'd or having some kind of sedation performed on them. But one of the things that we learned, and this was a study that Dr. Bledsoe out of Las Vegas did, was that I think a lot of people think they're really good at the GCS. And one of the things that I found anecdotally going through my training with about 250 people is that we're pretty good at 3 GCS scores. 3, right, because that's easy. Yeah. 15, because that's pretty easy. And for the most part, we're pretty good at 14. But anything less than between, I would say 5 and 13, there's a lot of deviation and a lot of randomization on what people might score somebody. So Dr. Bledsoe did a quick study. It was a video vignette. They basically had 10 scenarios, and they sat people down in front of the screen and said, okay, we're going to show you a scenario real quick, and they were about 10 seconds, 15 seconds each, and I want you to tell us what their GCS is. And basically that study confirmed exactly what I just said, is we're good at 3, 15, and maybe 14. So we spent a lot of time making sure that people can actually calculate a correct GCS, because that's a huge part of being enrolled in this trial. So we probably, half of our training time was spent kind of going over some slides, but big chunk of it was making sure people can go actually figure a correct GCS. So it was pretty interesting.
And I would agree. I'm doing this now 23 years. I still, and I've got a pretty darn good memory, and I still have to look at that GCS chart.
Absolutely.
It's just something we don't.
Yeah, I mean, I could do a whole 2-hour class on the GCS, and I actually found it extremely fascinating, the different opinions, and it makes a huge difference when you do have that card. So we actually had ROC build us a sticker that we put on the outside of the kits, and we have pocket cards for the crews just so they can have something to refer to real quick and talk about that GCS, because it's super, super important. I mean, I guess at the end of the day, if they say the GCS was 12 or 9, then of course we're going to believe them, and that's where we're going to go. But we want to make sure that's accurate, because in enrolling the wrong patients into the study, that doesn't do anybody any good. So
I would agree. Yeah. That's great.
Yeah.
So based on the inclusion criteria now, is there any specific exclusion criteria?
Yeah, there's a ton of it. Really, it's pretty much people that are obviously like a GCS of 3 and their pupils are not reactive. If we don't know when their injury was, we're not going to give it, because again, we learned from those studies that after 3 hours, it was actually harmful. So if we don't have a reference for time of injury, we're not going to give it. Let's see here. A couple things. And interestingly enough, if we know the patient has a history of seizures or are having a seizure in front of us, we cannot get them, because one of the things they found out kind of as TXA was growing up, so to speak, was that in large doses of TXA, it actually lowers the seizure threshold. So if there's any clinical suspicion that they're having a seizure or they have a history of it, then we're not going to enroll them. And also people that are obviously having an acute MI or a stroke that we know about, and that was kind of a hard one to talk about, because we don't routinely do 12 leads or have a reason to suspect somebody's having an acute MI that has a TBI. But we talked about situations where if it looked like a medical event preceded like a fall or a car accident or something like that, then they would not be able to go in there. Dialysis patients are not going to be enrolled, because TXA is pretty much cleared all renally, so we're not going to try to make them any worse. If we do CPR on somebody, let's say we start the infusion and they end up having a traumatic cardiac arrest, then we will stop the infusion. Of course, the 3 Ps: pregnancy, prisoners, or pediatrics. Those guys never get enrolled. And then part of and again, I hate to belabor it too much, but for those of you that know about medical research on human subjects, right, it's kind of a big deal. So there's a huge process that has to be done, and a big piece of that is kind of letting the public know, hey, this trial is going to be occurring in your area, and there's all kinds of public information sent out about TV commercials, radio ads. There were things in the newspaper, there was online, so people can actually opt out, and they actually get a bracelet that says no study. So in case they were to be in this situation, and they would not be enrolled at that time. So interesting stuff.
Is there anything else as far as the study that you want to talk about or go over that you found interesting as far as throughout your training?
Well, like I said, I think, when you go look at the CDC data that talks about kind of like how is traumatic brain injury, what's the kind of the spectrum, what does the data say about, what's the prevalence of that, and it's pretty interesting. And I kind of looked at kind of our local data. So basically what the CDC says, and I think this is probably 2012 data, but about 29% of TBIs are caused by a fall, whether that's a ground level fall, off a ladder, second floor, or whatever, and then another 20% from motor vehicle accidents. So that's nearly 50% of all traumatic brain injuries are occurring from those two mechanisms of injury. I would say in the Portland metro area, and this is Clackamas included, lots of bike riders. I mean, a huge amount of bikes and pedestrians. So our percentage of those people being struck by vehicles is actually a little bit higher than the national average. So I found it very interesting that nearly 50% of these TBIs, and again, that's the full spectrum from a diffuse axonal injury to a full-on, someone that's going to need care for the rest of their life. So it's a big spectrum. So pretty interesting stuff.
So, Mike, one of the things that I've always found interesting, and I've heard this taught by other EM intensivists around the country, around the world, is, when you look at a medication, and we give hundreds of medications, but TXA specifically, when we give this, we need to give this within 3 hours of injury. And it's very interesting that if we give this after 3 hours of injury, the CRASH 2 and MATTERS trials showed that you actually have poor outcomes. So is there any safeguards that your trial is going to have, and I think you elicited to that as far as the 2 hour mark is
right.
Kind of that safety zone. So I just think that's very interesting, and I'm curious to find out if they ever truly figure out why that is.
Right. Yeah. And and like I said, in CRASH 2, if it was 1 hour or less, they absolutely had the best outcomes. And I'm sure there was another large, there's 2 minutes to 59 minutes that was within that 1 hour, right? So we don't know exactly when it is best, but like you mentioned, we absolutely know that if it's given greater than 3 hours, it is really, really harmful for the patient.
So, Mike, as far as your protocol goes, and you elicited, are you going to have this in a pre-mixed box where the medication is pre-mixed, or are your crews going to have to mix this? And if it is going to be mixed, can you explain the way you guys are going to mix this and administer it?
Yeah, it's a pretty interesting thing. So basically, our TXA kit comes in basically like a canister. It's about 8 inches tall, about 3 inches wide, and inside there it has the study drug that's kind of in some foam. It's in a vial. And then they came up with this really cool device. It's called a vial to bag adapter. And you can Google that, check it out on YouTube or whatever. But it's a really cool device that you actually hook up to your IV bag, and then you snap this lid on top of your vial. And basically, when you squeeze air into the vial, it basically sucks out the medication into your bag, and then you just shake it up and you're pre-mixed. So it's actually really kind of cool. It's not intuitive at all. We spent a lot of time, with the crews hands-on trying to get them to use this thing. And then ROC finally came back and said, well, we were trying to make sure that everybody the procedure was the same for everybody. That's why they came up with this vial to bag adapter to put in the kit. But they kind of wavered on that and said we can actually just draw it up with a syringe now, which is going to be way, 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 way easier. So basically, it's going to come in like a 20 ml vial. We're going to draw it up. We're going to mix it in a 250 cc bag of sodium of just saline. And like I said, we'll infuse it over, 20 minutes or so, or however long we're with them. And that's really it. So that's the only part we have to do is just draw it up out of the vial, put it in the 250 cc bag, and then we're good to go.
All right. Well, Mike, I just want to say thank you for all you listeners. What Mike's going to do, we're going to actually put a blog post on the FlightBridgeED website. We'll add some pictures and some links, and and it'll be very informative. So you can go to the website and click on the blog link, and you can read about all this. As always, if anybody has any questions regarding this trial, you can always email me. You know that I love answering questions. I love to interact with our listenership, so keep those coming. Mike, do you have any contact information if people have any questions regarding this?
Yeah, you bet. You can email me, and I'll give it to you guys. My name is Mike, so it's mike.verkest, V as in Victor, ERKEST, at FlightBridgeED.com. Hey, and one other thing real quick. I just want to let people know, if you're interested in the ROC and the different studies that they do, all you got to do is just go into Google, type in ROC, and then you can put University of Washington or ROC EMS or anything like that at all, and it'll pop it right up, and you can go check out all the cool stuff that they're doing there.
Yeah, and what we'll do also is we'll put links in the show notes to the study, to ROC, to different parts of the country that are actually contributing to this study. And again, I just want to say thanks to Mike. It's been great having you on here. Great to do an interview podcast. We've been wanting to do an interview podcast for a while, and I've got quite a few scheduled.
Good deal.
And I thought it would be best to have a good friend and colleague jump in and do the first one. And when I was out in Portland 2 weeks ago when we did the review class, and you had told me about this, I thought this is a perfect interview podcast. I hadn't heard of this at all, and so I really think that everybody really needed to hear this. So I really appreciate your time.
Absolutely.
Of your night. I know it's late, and so I really appreciate it.
Absolutely. I was happy to be here, Eric. It was great talking to you, buddy.
All right. Well, on behalf of myself and Mike, we just want to say thanks. Keep all the emails coming. Check out the website. Check out the blog. Remember, we have the YouTube channel. It's all free education. And if you are looking for a review class, you can always email me. If we don't have one scheduled, we'll schedule one in your area. We do have a few scheduled right now, so go online and check that out. And if you have any good case studies, remember, we're always looking for good case studies so we can continue our Nightmare series. It's a very successful series that we do with our podcast, and I need those cases coming to me. So on behalf of all of us at FlightBridgeED, I just want to say thanks, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.